Support comes from Hampton Roads Community Foundation, partnering with donors from all walks of life to improve southeastern Virginia through grants, scholarships, and leadership initiatives. Learn more at hamptonroadscf.org.
Hello, everyone. I'm Barbara Ham-Lee. What would you expect upon meeting a person who served as a treating physician to a president, an entrepreneur, a former director of the National Institutes of Health, and a presidential envoy? In this next hour, you'll meet Dr. Elias Zerhouni. And if his book is any reflection of his true personality, you'll find him to be intelligent, compassionate, humble, and keenly aware of the American healthcare system and its impact upon our health. The book is called Disease Knows No Politics, and we'll talk about it next on Another View, right after this national, regional, and local news from NPR and WHRO News.
Discussing today's topics from an African-American perspective, this is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Ham-Lee. Before we get into our conversation, let me quickly tell you about an event that is coming up on September 12th through 14th in Virginia Beach. It is the first annual Hampton Roads Regional BIPOC Pride event, and it is presented by Thriving Trans Men of Color in participation with the church, Virginia Beach Unitarian Universalist Church in the city. And they are holding a huge 3-day event. Friday, September the 12th, there'll be workshops and panels on leadership, wellness, advocacy, and cultural healing. On Saturday, the 13th, they're going to have a big community festival. And on Sunday, there's a scholarships and awards ceremony. You can find out more by going to thrivingtransmenofcolor.org and check it out if you are interested in attending. So it's the last Thursday of the month, which means my friend and co-host of Another View on Health, cardiologist and market director of community health improvement and engagement with Bon Secours, Dr. Keith Newby, is right here with me, the man with the longest title on the planet, right?
Oh, tell me about it. Sometimes I got to think about it myself.
How you doing?
I am doing well. And yourself?
Good. I'm doing good. I cannot complain.
Last semester, Barbara.
This is it.
This is it. MPH degree, here I come.
Oh, that's fantastic. That, the one thing, and one of our guests today also talks about this too, but the ability to continue to educate yourself.
Absolutely.
And to be able to, your work in the public health arena is going to be extremely critical.
Yeah, actually, this has been one of the most rewarding degrees I think I've had, short of my medical doctorate, of course, but it's just integrating the two together, which is what I think we really should be doing anyway, because there's so much overlap, but one without the other is not as good to me as both of them together. So it's really changed my whole outlook to medicine. So I really love the learning process.
Wow, that is awesome.
I don't like writing papers anymore. I'm sick of writing papers.
How many papers do you have this time?
1, 2, 3, 4, 5, 7 or 8, I think.
7 or 8. For this semester?
For this semester.
Oh, wow.
But that's it, though.
Wow. Well,
short-timer syndrome.
Our guest today is no stranger to Another View. Dr. Elias Zerhouni was on our show a few months ago, if you remember, Keith, as we discussed the doctor shortage in America. Yeah. Now he has a new book. It is called Disease Knows No Politics, a medical and political memoir that is so very timely in the midst of federal cuts in healthcare, including medical and science research and staffing and Medicaid. Welcome, Dr. Zerhouni, to Another View. How are you?
Thank you for having me, Barbara. Thank you.
It is so good to have you on. And Bruce sends his regards, believe me.
Thank you. Thank you.
So, yeah. Dr. Zerhouni, I got to ask you, talk about a disease having no politics. I really would love to get your take off the bat about what's happening at the CDC right now. As the White House last night firing the director and all of that's going on. She says that Robert Kennedy Jr. is weaponizing public health. What do you take of all of this in terms of our public health today?
Well, it's a good question. I mean, the title of my book is Disease Knows No Politics, because it was based on my experience over 50 years, between 1975 and 25 that I recount in the book. But politics does know disease, The reverse is not as true as you would think. And this is an example of politics getting really, really inside the evidence-based public health data we've had for years. And there's no question that this is not even politics; it's agenda-driven actions from, Robert Kennedy, the HHS secretary, who's had 25 years of campaigning as a zealot against vaccines, thinking that vaccines are the cause of chronic diseases with no evidence, thinking that vaccines do more harm than good with no evidence. And so we are in an evidence-free world where zealots and conspiracy theorists are taking over the work of very, very capable scientists at the CDC. I mean, CDC is considered the gold standard in the world for epidemiology and understanding diseases. So to me, it's really a form of chaos, frankly, inappropriate and dangerous.
And then it also confuses people in terms of what are they supposed to do? Do you get the vaccine? Don't you get the vaccine? I mean, it causes unnecessary confusion.
Yeah, but that's the point about being a zealot about something and be evidence-free. You're trying to basically brainwash people for your theories and what you believe in so strongly, and other conflicts of interest that you have, and every part of life. This is what we have. And so it confuses people, and it leads to new outbreaks that we've never seen before. I mean, measles outbreaks since 2003 is the last one I remember. I was the NIH director then, and it was in California. And then we had several in Germany. Why? Because of the anti-vaccine, folks who absolutely believe that measles vaccines, created autism. That connection, which has been disproven for the past 22 years, over and over. I ran studies of thousands of patients with and without the vaccine, and never did we get any signal that, in fact, the vaccine was responsible. Then they came up with the thimerosal, the preservatives in vaccines, and on and on and on. So it doesn't stop. It keeps confusing people, and it makes people make decisions that are dangerous for their children. Yeah. So we've had 3 people dying of measles in Texas, and I'm sure this will happen again because of the relentless campaign against vaccines that now has reached the highest level of government, to the point of firing competent individuals who understand what's behind this. I mean, listen, we used to die by millions when vaccines did not exist. Wow. What are we talking about? It's irrational.
Well, I even think about when the COVID vaccine came out, and I'm sure, Dr. Zerhouni, you remember some of the chaos with that, but I tell you, as a practicing physician, when I was observing the number of deaths that were present, and I remember the vaccine kind of started coming out, I think it was November of that particular year, and then it started getting widespread use December and January. I saw the death rates drop precipitously after the vaccine was introduced. I mean, we're not even talking, I'm not even talking about this coming off of data that I can't even prove. I mean, I saw it in firsthand. I saw the drop in the number of deaths and hospitalizations once it really started becoming widespread use. So, I mean, when you see that, then you see people, it caused me to have a heart attack or it caused this and that. I'm like, listen, you got hypertension, you're diabetic, your sugar's 400, you got cholesterol of 400. I say, I think you have other reasons why that heart attack kicked in, but you think about the overall, the relative risk-benefit ratio. There's no question to me about that. So I'm with you 100%. I mean, it's like non-factual information people come up with, and they run with it, and all you need is somebody with a microphone, and they can convince people.
Yeah. I mean, this is a very good example of politics that influences disease policy, right? I mean, you fire the 17 members of the very established, respected committee on vaccines. You put your friends on it and zealots that have had opinions for the past 25 years. They're not going to change. I mean, this is chaos. It really is public health chaos.
So, Dr.
Unjustified.
Zerhouni, when you looked in at the NIH today, so the Trump administration proposed a 40% reduction in the 2026 budget. That was rejected by the Senate, and they actually approved a modest increase. But there's still uncertainty about that. 1,200 positions eliminated in an effort to downsize. Then they asked employees to come back because of perceived mistakes in the termination process. So as the former director, do you recognize NIH today versus when you were director?
Well, it's different. I'll tell you, the thing that shocks me is this. When I became NIH director, I was appointed by a Republican president, President George Bush, okay? So when I came there, and the folks at the White House told me what the mission should be, you make it more efficient, but let us tell you that the president is committed to doubling the NIH budget and doing something about the HIV/AIDS pandemic around the world. I really like that. So for me, it was like accomplishing a mission that was a positive mission. Today, same party, complete opposite. No, we want to cut the budget by 2 and stop doing anything about HIV/AIDS. So it's like a dystopian universe that I'm living in, and I'm thinking about the consequences. And I've been, telling everybody who can hear it, I said, this is very dangerous. We're going to lose our leadership in biomedical research, which has been hard built and really requires a lot of people. So, for example, people always think, it's money, we can cut the money and put the money back. And no, biomedical research, scientific research is an investment, not a subsidy. It's very different than subsidizing corn or subsidizing sugar, That doesn't create value. But what we do at NIH and all the science agencies create the world of the future. We wouldn't be the leaders in AI and all of the scientific fields above every other country in the world without that investment since 1945. It's been steady, smart, very, very, very instructive of what we needed to do. And the key, and listen to me on this one, is this. If you cut the budget of NIH by $1 billion, you lose 8,000 scientists in America. The young ones, they don't want to go into science. The ones who are established leave. And then what you end up with is the ones who are already established, the senior guys stay, and you've lost the whole generation of new scientists that carry the new waves of science. So the danger here is not a brain drain that some people are saying, we're going to lose brains. No, we're going to have a brain loss. It's almost like a lobotomy. And for each billion that you argue is wasted, prove it if you could, please. And I don't dispute the fact that there's always improvement you can make. You have a bloated bureaucracy, you're not efficient. Okay, I agree. It's not 40% of what we do.
Yeah.
And 40% of what we do will lead to essentially 100 to 150,000 young people leaving science. Where does that leave us? So that's what I testified to. That's what I said. And I'm glad to see that some cooler heads are prevailing in the Senate, hopefully in the House also, and will avoid the disaster. But right now, it's uncertainty for everybody. And you know how uncertainty works, right? You stay away from risk.
Yeah.
You say, no, I'm just going to be a doctor. I don't want to do science. I'm just going to go to finance or industry. I'm not going to do research. I'm just going to do something that pays me well for my lifetime of commitment to education.
So let me ask you this: for people, Joe, the average citizen, explain in layman's terms exactly what the NIH is and what it does.
Okay, so the NIH was created in 1945 by President Roosevelt. At the end of the war, the president and his advisors saw how good the relationship between universities, research universities, and the government were. The atomic bomb. It came from basically research universities and then was implemented by the Army. And then you look at radar, you look at all the defense industries of that time were created by a public-private collaboration where the government funded very, very basic research. And the universities invested in their buildings, in their students, in their professors, and so on to create the workforce, the human talent that America needed. That's how we won the race to the moon, because in 1945 the thing was done. So when you look forward, what I think you're asking is, if I understand your question, is what are going to be the implications, right? Is that what you?
Yes.
So think about it.
Because I think a lot of people who are, just your everyday average person, they hear National Institutes of Health, they hear NIH, but they don't have any clue as to how that impacts their lives.
Oh, so let me give you an example. So 90% of biomedical research in the U.S. is funded through the NIH. It doesn't stay at the NIH. NIH only uses about 10% of the budget for its own organizational needs and internal research that others cannot do. 90% goes back with a competitive process. You don't just get money. I mean, I never gave money to any universities. They had to compete.
Oh, you didn't just throw the money up in the air and then...
No, I wish I had. But what happens is they come with proposals and then we fund them. But the key we pay attention to is we drive what the priorities are, okay? We say, look, I mean, the Human Genome Project, we took the lead on that because we said that's very important. And then on coronavirus, we did 20 years of research, which allowed us to create a vaccine in 9 months. So this is what NIH does. It's sort of a guide, but it doesn't do the research. The research is done at the universities, the colleges around you, and it goes all the way to your community. There is not a single district in the U.S. that's not touched by NIH research.
It's tough to get a grant through NIH. I mean, I've been down that road before. I mean, they are very specific, and you have to be as detailed, but not over details. Like they have specific requests they have, but they want you to have factual evidence of what you want to do, why you want to do it, what's your goals, and they are very specific. So it's definitely not we just go hand it to you because we like you.
Right.
I mean,
there's no handouts.
No handouts.
And you know that because of the statistics, right?
Yeah.
We only fund 20% of the proposals. So out of 100 proposals, we fund about 20. Today, with the cuts and so on, it's going to 4 to 4%. If they cut the budget the way they're talking about, it's going to go down to 4%. So imagine you yourself going for a proposal where 96% of the time you're turned down, you quit. So you will quit. And that's what I'm afraid of about the young scientists. Sorry.
And I was going to say, and some of the grants that were already approved then have been rescinded. Even have they not?
So yes, I mean, so some of them are political because DEI is absolutely, a no word to be pronounced anymore, and that's what it is. But that's a small amount of money. It's not 40% of the budget, I can tell you. Yeah. And then the second thing is you're really talking about, the war against universities. Yeah. So because the grants are granted to Harvard and Columbia and so on, but then there's a stop order that's put out to put pressure on them for political reasons, have nothing to do with science. Yeah. I mean, they're cutting cancer grants, they're cutting pediatric grants because they want to squeeze the universities for political reasons. They don't want them to be woke, they don't want them to have anti-Semitism and things like that, so which are completely unrelated to the health of the American people.
Exactly.
So my question to you would be this, and what my fear is one thing if you look at just a single administration and they go and cut, then the next administration comes in and they say they choose a refund, but the domino effect that I'm worried about is how this will affect long term, because if they make the cuts now, people start leaving science just because you come back and say we're going to start giving them more money doesn't mean they're going to come back.
Exactly.
So I'm worried about the more long term.
And there is that fear of even if the government comes back, that it won't go away again. And so people are planning around it as opposed to depending on it from now.
Yeah, two things you got to think about: the uncertainty. Number one, is it a career I can have?
Mm-hmm.
And then the disruption, and the disruption is not recoverable. People think, oh well, it's okay. They'll suffer for a couple of years. They'll come back. Absolutely not.
Yeah.
Science, the way I know it, and I've done 50 years of it, is like cooking a very complex recipe. All right, you have to have the ingredients. You have to have the students. You have to have the PhDs. You have to have the ideas. You have to have the laboratory. And then you cook it. You start cooking. Imagine yourself coming to me and say, oh, I'm going to cook you a meal. And then in the middle of that, they take out the tomatoes, they take out the things, and you say, hey, no, we're going to stop here. And then they come back a month later and say, oh, can you finish your meal? Why? So it doesn't happen. It's irrational.
Yeah.
So you were born in Algiers. You made your way to America. First of all, let me tell you this. I honestly, when I was approaching the reading of your book, I thought to myself, okay, this is going to be very heavy and scientific, and it's not going to make any sense to me. And it is warm, and it is engaging, and you teach life lessons from it. Is it really a reflection of who you are?
Yes, absolutely. The one thing I've always tell people, and I think people who know me would say that, is don't let success get to your head, right? I tell my students, I said, guys, the gates for success are very narrow.
Yeah.
And the thing that will, and to really, really be successful, you have to go through multiple gates of success, not just the first one. Well, I've seen students who get to that narrow gate of success, then their head swells up, and they can't get to the second one. So I tell people, be careful, keep your head, not swollen, be humble, and reach people the way where they are. Don't tell them, look, if you don't want to understand what I say, that's your problem, not my problem. No, it's my problem.
Yeah.
So that's really part of my success through life has been the ability to communicate in a way that's understandable and hopefully logical, but also data-driven. If you read my book, I go by data.
Yes, you do.
So that's what happened. That's what happened when I came here. I was lucky to go to Johns Hopkins University. I was lucky to go to EVMS. That's where my first big research happened, and I created a company called CIRS. It's Computerized Imaging Reference Systems, which still exists. I have no connection anymore, but it still exists. It has like 100 employees and families that are supported in Norfolk.
Mm-hmm.
And so I think people, when you look at that, you realize that $1 of research creates $3 to $4 of economic benefit. So here's another reason why you shouldn't mess around with the engine that has made America so successful. Yeah. The second thing I'm also saying, Barbara, is I want to really thank America, because what I lived through my memoir, my book, my career, is the American dream. And as I said, many times, I say it would not have happened in any other country. So all the things that don't work very well and all the politics that we have, and at the end of the day, there's something special about America. I mean, 50% of all the Nobel Prizes are actually immigrants. I'm the first immigrant director of the NIH, but I tell you, there are so many talented people that have created so many enterprises. Look at the leaders of the tech industry, whether it be Microsoft or Google or NVIDIA or, Sergey Brin, who's from the region and so on. So the issue about immigration, like throwing the baby with the bathwater, should be thought through a little better. We have succeeded because we've had very quality policies that encourage the best and the brightest in the world to come here and stay here. I'm one of them. So thank you, America. This is the American dream.
If you're just joining us, we're in conversation with Dr. Elias Zerhouni, author of Disease Knows No Politics, and cardiologist and market director of Community Health Improvement and Engagement with Bon Secours, Dr. Keith Newby. 757-440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. What questions do you have for Dr. Zerhouni? Give us a call, 757-440-2665 or 1-800-940-2240. So, Dr. Zerhouni, you and I have a lot in common. I am from Baltimore, born and raised in Baltimore. I am so happy that you and your family were able to change your perspective of my city, my hometown, from when you first arrived until you had a chance to spend some time in Charm City.
That's right.
I'm scared to ask any further on that one.
I recount that in the book, Barbara.
Yes. You were kind of, where am I, and why am I here?
Right.
Oh,
That's
man.
Right.
Oh, gosh.
Well, I have a question for you, Dr. Zerhouni. So, it was kind of interesting. I'm finishing up a degree at UNC now in public health. And one of the questions I've heard a lot of the students ask, because they were asking me, well, what are you going to do after you finish? I said, I'm back at my regular job. I said, I haven't left. I said, I'm straight. I'm good. I said, I'm just incorporating what I'm learning into programs and things I want to develop. But they're kind of concerned and nervous about, their perspectives for the future. Right. Do you have any advice for maybe, because how do they navigate at this stage when they come out?
That's a great question, Keith. And when I tell people about the book, I said there are two stories in the book. One is biomedical research science from 1975 to 2025. That science got stronger, better, and dominant in the world. Okay. At the same time, I recount the evolution of the healthcare system and public health, which, in my view, when I came, I thought it was the best in the world. But it has gone down and down and down and down to today, where you yourself, all the frustrations we face. So here's one thing. Something that went up, we're going to cut it, and we're going to completely destroy it if cooler heads don't prevail. Something that is not working, nobody's talking about it. They're talking about cutting Medicaid. They're not talking about fixing the system. So to go back to your question, I think we're going to need, if you look at the evolution of healthcare right now and the potential for AI, for really managing population health, for really using public health angles. When you're a doctor today, you have a patient-doctor relationship. You treat patient X. But I tell you, there's a dimension that is growing, in my view, which you're going to treat populations, as a doctor. Why? Because you'll have the tools to do it. You'll have AI, reminding the patient, hey, you need to do this, you need to do that. You won't have to spend, 30 minutes of the consultation explaining it. So you're going to multiply the power of doctors and public health, especially doctors who train in public health, to understand that chronic diseases are still our number one problem. By the way, that's the one thing that I agree with Robert Kennedy, the HHS secretary. The priority should be chronic diseases and nutrition in this country. I totally agree with that. We are in the pandemic state, relative to that. And we need to do something because 80% of the troubles that we have in healthcare come from that. Yeah. So anyway, my point is the future is bright, provided we continue to invest in research in new technologies that apply not to the individual only, but to populations at large. And that should be adapted to the region. As I say in my book, I traveled the U.S. Let me tell you, the U.S. is not one country from the public health point of view. It's very different from one side of the country to the other. You go to Colorado, it's very different than Minnesota, very different than Mississippi. So
absolutely,
you need to adjust regionally to the health system. And right now we have a centralized system, which is controlled by Washington and the Congress and special interests who are really basically extracting an enormous amount of compensation with no value. That's why we pay twice as much as any other country, developed country, and we get half as much in terms of healthcare.
So you really spent a lot of time helping, as I interpreted it from the book, scientists and the medical profession to come together to solve problems and to disrupt the silos. Has that continued, do you think? And is it still multidisciplinary in terms of how we approach disease?
Yeah, something, I discovered that by chance. I mean, a lot of the things that happened to me were happening because of experiences on the ground. When I was doing my research in radiology, which I did at the VMS, I was there when I was on the faculty there, and then at Hopkins, I realized we couldn't do our research without having engineers, without having computational biologists, who had, the scientists in physics and mathematics and so on. I realized that, hey, the world of the future is going to be a multidisciplinary world. And how are we organized? Well, departments, discipline, you can't cross over from one to the other. So a lot of the reasons I was appointed as NIH director is because I was telling people the world has changed. We need to change. So the multidisciplinary angle is really what I was saying is absolutely critical. Healthcare is the same thing. It's a team sport now. It's not like one doctor treating everything. We have all these specialties. The problem is that they're isolated from each other in many cases, and the solution has been creating these huge healthcare systems and then consolidating all the insurance companies into these major monopolies, which are really very, very difficult to change.
One of the issues that people do face in the healthcare industry also is the decision-making on treatment being made by the insurance company versus the medical profession. And, do you see that coming together at some point or figuring out a better way for that to be handled?
Oh, I tell you, this is a fundamental issue. And it started in the 80s. I experienced that myself. Actually, I benefited from that because I came up with a test at EVMS and at CRS to prevent unnecessary surgeries for lung cancer, okay, to make it simple. And at the beginning, nobody wanted this invention. So that was my first patent. They said, no, we don't want it. Why? Because the best customers of radiology at the time were surgeons who operated, needed the CAT scans, needed the thing. And they said, we're not going to do this to our best customers because my technology will stop about 50% of the unnecessary surgeries. All right? Fast forward, that was 1980, 81. Fast forward, 1985, I proved with a scientific study at multiple universities that we could actually reduce thoracotomies by 33%. And people were saying, well, it doesn't matter, we don't want to upset the surgeons. Until the insurance company says, oh, by the way, from now on, if you want to do a thoracotomy, which is the surgery that opens the chest, you have to do the Zerhouni test. That was the first example where I saw, wait a minute, they're practicing medicine now. and you know something? It just grew from there.
Yeah.
Today, denials, pre-authorization, all of that is a way for these companies to preserve their bottom line because the utilization of insurance is what determines their bottom line. And so they're driven rationally. I mean, I don't blame them. That's what the business requires. Otherwise, your stock will go down like it did with many of them because you're unable to control costs.
But then there's also patients that may not get help because of this.
You know something? You have to read the chapter once you get to that. It's at the end of the book when I recount what I observed of the healthcare system and what has happened. You know something? Which is the part of society that is not represented when decisions are made about healthcare? Tell me.
The patient.
You know which one?
The patient.
The patient.
Yeah.
And you know what we say, right? If you're not at the table, you'll be on the menu. And that's where we are, my friends. My friends, look, the American patient is on the menu of the table of all these special interests that have essentially made the cost of healthcare unaffordable to 50% of our sort of population. I mean, you talk to people, they're afraid of going to the hospital. You know, you listen to them, and you can see that a great number just can't afford it anymore. It's not accessible. It's not affordable. Why? Because we pay twice as much for things that actually don't provide value to the American patient, and the patient is not at the table.
So how? Go ahead,
Keith. Two
mm-hmm.
things that I'll jump in on. One was, back in, I'll try to make this as generic as possible, but back in early 2000s, I remember an article came out about, when the mortgage companies were on all the issues with the mortgages that came out, and bank industry got into trouble.
Yeah.
Mm-hmm.
So there was an article that came out about, when the government bailed the banks out, they turned around and started bonusing their people money out of that fund. Mm-hmm. So, of course, everybody was up in arms about that. But then there was an article that came out, I'll never forget this, talking about health insurance companies and what their CEOs were getting bonus-wise. And I won't say any names, but I'll just say one in particular. Their CEO that particular year, so we're talking mid-2000s, $30 to $32 million bonus for that particular year for the CEO of this health insurance company. And you sit there and you look back and you say, okay, you're telling me, and I have to fight. And the biggest challenge I have is if I have to, like I have patients that are on a medication that's been doing them well, blood pressure-wise, for years. And all of a sudden now they have, we don't want them on that anymore. And because it's still either brand name drug or whatever. Mm-hmm. And, so you have to then justify it. They're going to find a way to not justify it. So you get these fights that you have to do, which, and I hate to say it, but it's wasting my time because instead of taking care of patients, I got to go get on the phone with these people and try to argue
why they should have the medicine that you prescribe.
For something that, and then half the time when you get them on something else, and sometimes generics okay, but sometimes they're not, and sometimes patients need what they need. Then you fight with that, and it's just that's where I think a lot of people are getting out of medicine because they know we don't have the time when you work these hours that we have to work to get on the phone arguing points. Right. And that's where you find people not wanting to do with this anymore. So that's where I see a bigger issue is just he's absolutely on point. It's the system in play that really keeps you from getting anywhere. And it's almost like you have these people in the white ivory tower telling you what you can and can't do. So you can't
somebody with a book that has a script.
And so you run into that as well.
Yeah.
So it's those kinds of situations. And to me, it's hard because as a physician, I've always loved people. I mean, and you know me, how I am with patients. To me, that is like my end all be all. So you telling me I have to fight or somebody's not worth saving a life because of their age or whatever, I can't do that. I mean, intrinsically, it's not my DNA to say, okay, you're not worth it because you're above a certain age. I understand where some of the dynamics come from, but each person is a unique individual with unique individual characteristics, and I can't put everybody in a bucket.
In a box like that. Yeah. Dr. Zerhouni, then how do we get patients to the table? I love that analogy of, why who's not at the table and who's on the menu. So how do we get off the menu and onto seated at the table instead?
Yeah, Keith said something very important. He highlighted the contradictory nature of, the players in healthcare. And he's talking about a CEO making $30 million and succeeding by not providing services to patients who need that. He gave the example, right?
Yeah.
And then he says in the middle, the doctors has to pick up the phone, argue with the nurse who wouldn't give their name and whatnot and what guidelines and so on. I know the circus. I went through this in a big part of my career. So to me, what the image I give to people, my grandson asked me the question. He said, how does that not work? I said, imagine if you had a car with two steering wheels, two drivers, one wanting to go left, one wanting to go right. One being driven by profits and by a bottom line, one being driven by what they want their mission to be, first do no harm and help the patient, right? So what would happen in a car like that? I mean, it will break into, the tires will get used because it's not advancing anywhere and so on. that's what we are. That's what we're having right now. So when you ask me the question, I think we need to realign the fundamental drivers of the system. And I'm not saying it should be a government. People talk about universal government system. I don't believe that would work because I've been in bureaucracies in the federal government. They're not the best for good reasons because they're politically influenced and motivated.
Yeah. Mm-hmm.
However, I think you need to break the problem back to the patients. And so I call it not a revolution, but a devolution. Give people back to the regions that are epidemiologically similar, where they would have to use the funds and the resources in a different way than other regions. And we don't have that. And I give the example, we have that for the economy. We have the Federal Reserve with 12 regions. We don't have that for healthcare. Yet, if you go to Canada, they have like 12 regions, Germany 16, the UK 8, and they manage very close to the patients. And the patients is all like parent-teachers association. The patients in those regions are on the governing boards of these regional health organizations. That's my view. People think it's completely naive and crazy. It would never happen. Why it would never happen? Because look at the reforms that have gone through. I remember when George Bush wanted to have prescription drug coverage for seniors. At that time, if you recall the stories, people were not eating to buy medicines. They had to choose. It's either you eat or you get treated. And so they went and they said, we should do this. I thought it would be a slam dunk for Congress to do that. I mean, spending more money for more people, that's popular. It barely passed. There was one vote. I remember up to 2 o'clock in the morning fighting and trying to convince Congress to go ahead for it. Fast forward, Obamacare, same thing. Who would argue that 40 million people uninsured is things to be fixed and it's a good thing for the country, right? Who would argue that? Slam dunk. No, it was a fight to the death, right? So I'm considered naive because what I'm proposing would require some really gutsy moves, and that is what I call a devolution solution.
Well,
not a revolution from Washington. Washington will not fix the problem.
Well, but I tell you the interesting thing about it though is you think about where all this underlies. It's not that I think what you're saying is naive, and they have to take it out in a different context. It's naive in the current system we have, because the current system we have is driven by money. You think about it, to get elected in office, you have to have money. Who's giving that money? People that's going to want favors, and that's where, to me, the issue comes in. It's not, I don't think what you're saying is naive at all, because our current system is broken. There's no question about that.
But there's going to have to be someone or some organization or something that will be able to step up, because as Dr. Zerhouni just said, he doesn't think it's the federal government. So there's got to be somebody else that steps in to say, we have to fix this.
Well, the issue comes as regulations, and who dictates those regulations that you have to abide by. Yeah. So you still go back to the government to a large degree, and you have to just cast in the whole world, and then you come back up with something that works. But current situation, you think about it, what does it take? The reason he had all these problems because he has the politicians have these other people in their ear, right? Telling them, do you ever see? I'm going to tell you, this is going to sound crazy. You remember that? I don't know if you saw that movie Eddie Murphy was in. It was called The Distinguished Gentleman. Did you ever see that? I did see that movie. It wasn't as popular Eddie Murphy movie, but if you watch it, and I remember one of the guys was schooling Eddie Murphy, and he was saying, "Okay, do you believe in like free milk for kids? If you believe in this, I got this company that's going to give you X amount of money. But if you don't, I have this other group that's going to give you X amount of money. But it's all about dollars. Now, whether or not that's true or not, I can't say, but it's just the conceptual idea of this is, really, if you could, I really would like to take healthcare out of that scenario. You can't look at just domineering on money that you make, and look at it for the basics of what it is.
What it is, So
actually, one thing in my conclusion for that chapter, I said there are 4 things that you need to do. You need to find a way to depoliticize. You have to find a way to eliminate the middlemen, the intermediaries that don't add value. You have to find a way of regionalizing to get closer to patients. And you have to find a way to allow innovation. Regulation, the way it is today, prevents innovation. You have no way of doing anything new in Medicare or Medicaid. Why? Because anything new you do is a fraud and abuse. So I can tell you, I developed a test for CT scanning that would image the entire body in 45 seconds, okay? And then I went to Hopkins and I said, guys, why don't we waste our time doing CT of the head with this code, CT of the neck with this code, CT of the chest with that code. And oh, by the way, you cannot do two at a time. And all these regulations. And I said, look, I will give you the test for the entire body at a third of the cost of any one test. And then we'll do it as soon as the patient comes in at Hopkins. You know what? The general counsel said, you'll go to jail, doctor, if you do that, because you violate the CPT code and the ICD code and all these codes. Same thing in research. I mean, I kept fighting about not adding regulations on poor scientists. Scientists spend 30% of their time complying with regulations and mandated regulations that have nothing to do with their science. Wow. So I am for deregulation. All right? Yeah. I think we've overregulated the world because it serves special interests. It serves special interests.
One thing I noticed in your book, Dr. Zerhouni, is that a lot of the people that you mention in the book and that you hold up in terms of how they either assisted you or were somehow important to the topic that you discuss, and they're men. And I'm wondering, how do we get more women and people of color into the sciences, into the medical research and so forth? Because it just struck me as I was reading, every now and then you'd have a woman's name in there, but it was overwhelmingly male.
Right. So it's a reflection of the times. Okay. Yeah. I mean, I'm talking about 1975.
Yeah.
I tell you an episode which I recount in the book. My wife came with me. She's a physician, pediatrician. She wanted to be. And so she came to Hopkins. I was accepted in radiology, and she said, I got to do something, Elias. I can't stay at home. And I said, what about, because her English was not that good, I said, what about connecting with the medical students at Hopkins? And she said, oh, that's a great idea. So I asked my professor, I said, could you connect us with a registrar to get access to the names and connect with the female residents, medical students? She went there. There was 120 students in the last year because that was her level. And she said, well, tell me who were the ladies. There were 7 out of 120. Now,
is it any better today?
It's much better. It's much better. No kidding. I mean, it's really made a lot of progress. When I came from Algeria, a predominantly Muslim country, we were 50-50 in medical school. My wife and I were 50. I mean, our class was 50-50. So what you're seeing is a sort of a delayed effect from that period of time where women did not sit at the levels they should. Today, if I wrote this book, it would be completely different. When I appointed NIH directors for institute directors, I had 17 that I appointed. 7 were women. Okay, some of them became leaders of the Brigham Hospital, and on and on. So the world has changed. Even African Americans, there's more representation today than there was then.
Yeah, I was going to ask you about that next.
In the 50s and the 40s, you would have seen no Jewish representation either.
Yeah, right.
So things move. I think people are too negative. I think we've made progress. Look at the leader of the National Academy of Sciences is a lady. The national institutes, dominance with newcomers. So I think the age difference is what I think you're observing. You're saying my book doesn't talk a lot because that was the time. Yeah. My memoirs related to that period. Today, it will be a completely different picture. Not perfect, but better.
But better, absolutely. So the NIH today, is it still one of your major pushes was to create a new blueprint, a new roadmap for how the organization would run and how people would be more interdisciplinary in their approach to research and so forth.
Right.
Is it still that way today, or has it changed? I know it's different leadership, and I understand that, but I'm just curious as to whether that.
What I did was really new at the time.
Mm-hmm.
And it became the law because Congress liked it, and there was an NIH Reform Act of 2006.
Mm-hmm.
I think every organization, every scientific organization should consider a re-upping or modernization act, if you will. NIH is in that period of time. I hope they will get the advice from others, which I did. I consulted with 300 scientists from NIH, outside of NIH, over a period of 3 months before I came up with a roadmap. I didn't come up with my cooked ideas. I knew what I wanted to do myself, but I said that would be arrogant. So let's just listen. And I recount the process in the book. And then that process was really embedded in the NIH Reform Act, where there is a Strategic Management Review Board, which is more or less used, but it should really be applied today. Because if we're talking about major changes, it's like saying, the car has to change directions. Like I said, it was from doubling to housing, and so that requires. It's surgery. It's not butchery that we need.
Yeah.
And surgery needs planning, needs thoughtfulness, and that's what's lacking right now. Although I can tell you, the people who are appointed, when I talk to them, they have goodwill. The new director of NIH is really trying to do the best he can within his constraints. The director of the FDA, I mean, you should read his books, Dr. McRae.
Mm-hmm.
He wrote books about the healthcare systems, which I thought were very thoughtful. The same with Dr. Bhattacharya, who is the NIH director. So there is hope, but it does need data and thoughtfulness, which is lacking right now.
So we have less than a minute left, but I do want to say I think business students should also read your book because of your lessons in leadership that you have at the end of each chapter.
Yeah. I wanted to leave a message. I want to leave a message. But the one thing I'd leave you with is rock, pebbles, sand.
Yes.
All right? What I tell everyone, I said, if you don't understand rock, pebble, sand, you'll never be able to manage it. What is rock, pebble, sand? Is if you have a vase and you want to fill it with rocks and sand and pebbles, what's the most efficient way to do it? You'll find out mathematically that first you got the big rocks, and then you got the pebbles, and then you got the sand. Yep. The same thing is true. When I was doing the roadmap, I said, guys, you have 900 ideas here. Which ones are rocks, and which ones are pebbles, and which ones are sand? And then we focused on the rocks, and we found that, number one, multidisciplinary research. So we called that the research teams of the future. And then number two was the complexity of biology. So we said, we're going to do really a mix of computation and artificial intelligence, even at the time, to understand biology. And the third one was clinical research. I mean, lots of people don't participate. Those were the three rocks. Think that way and you'll be successful.
His name is Dr. Elias Zerhouni. The name of the book is Disease Knows No Politics. And I'm assuming you can go to Amazon and you can go online to your website to find the book, correct? Dr. Zerhouni.
Amazon, our website, Barnes & Noble, everybody.
Okay. Thank you so much for joining us today. We really appreciate it. And Dr. Newby, as always, thank you for your input. I really appreciate that too. Anytime. And audience, we hope that you've enjoyed this edition of Another View. So take the time out to share our show with a friend. Simply go to whro.org/anotherview, or you can go to Spotify, or you can go to any place where you find your podcast listening pleasure, because we're everywhere. So there you go. Next week on Another View, we're going to talk about a very heavy topic, but I think a necessary topic, and that is how to talk to our children about school shootings. In light of what happened yesterday in Minneapolis, we want to help parents to be prepared to have that conversation. Our theme music is an original composition created especially for Another View by Jay Sennett. Lisa Godley is our show producer. Jordan Christie is our audio engineer. And Dr. Barry Graham answered our phones. I'm Barbara Ham-Lee. Have a fantastic weekend, everyone. And let's get together again next Thursday at noon for Another View.
Support comes from Hampton Roads Community Foundation, carrying out your charitable wishes forever, whether it's helping shelter animals, feeding the homeless, enhancing the arts, or supporting students. Learn more at leaveabequest.org.